All right, welcome everybody. It is Health Talk, and we are just thrilled to have all of you here this morning on this Monday. Absolutely gorgeous day. John King is right over there. He's not so gorgeous, though.
No, I'm trying.
Good,
Working at it.
Good morning, John. How you doing?
I'll run that comb through my hair one more time, just for you, Peter.
All right, I'm Peter Christian, and joining us in the studio from Community Medical Center this morning, Dr. Elizabeth Sue. And, of course, this is not your first rodeo. You've been on the air here before. Is that correct?
Yes, I have.
Well,
Thank you.
Welcome back.
Thank you.
All right. We also have Kimberly. Now, I'm going right on a limb here. I'm guessing you're Irish. With a name like Kimberly Ryan O'Hara.
Yes.
That's got to be incredibly Irish.
It is.
All right. So a little bit closer.
Okay, sorry. There we go.
All right. So welcome to the show.
Thank you.
All right. Now, today we want to talk about breast cancer and the advancements that you folks are doing. So, Dr. Sue, the floor is yours. What's going on?
So we just wanted to talk about a new technique that we're using for localization, which basically means actually knowing where the tumor is before we take it out so that we can remove it adequately and center the cancer. And it's called radioactive seed localization. So it's a lot more comfortable to the patients. It can be done a week beforehand. Typically, cancers that you can't feel on exam, we'll put a wire in the day of surgery, and the wire is sticking out of the breast. And we use that wire sort of as our guideline as to where the cancer is so we can center the lumpectomy or the excision. Now we put a radioactive seed in, like I said, a week or so before, and the patients go home. It's very safe and very comfortable for them. It doesn't move, and they come in for their surgery. We can do earlier starts of surgery in the morning. But I do, personally, I think it helps a lot with a better margin, knowing exactly where the tumor is and centering that and excising it adequately.
So how does the seed help you find the tumor? So I assume there's some analysis before you place the seed.
Yes.
And it's just giving off a signal of, I'm here? Or does it kind of give you a blueprint you can look through and see the cancer responds differently to the radiation than the regular tissue, or what?
So the radioactive seed is actually a little radioactive isotope of iodine-125, and it's actually put into a capsule that is about the size of about a grain of rice. And typically after a breast biopsy, the radiologist put a tiny, like 1 millimeter clip in there that you can see on X-ray. And then the patients are brought back once the cancer is confirmed on the biopsy. Then we put the seed in the same location as the tumor. And then we use a little gamma probe counter, which is kind of like a exaggerated pencil that picks up radioactivity of that particular isotope, and then we can find that in the breast, and then we make skin marks and so forth to identify it.
Is that the least bit scary to a patient thinking, I've got something radioactive? Yeah. So I'm sure it's all safe and
It's iodine 125 or whatever.
Yeah, right.
Everyone just casually uses that stuff.
Well, we actually use another radioisotope, technetium, when we identify sentinel lymph nodes and do selective lymph node sampling, and that is a very short-lived radioactivity, and we use now both. It's very safe. It's a very tiny amount of radiation, just enough to pick up by our detector.
So why is there a huge advantage to using this radioactive seed than using the metal clip? I mean, you can find both things, right?
Yeah, so the clip is actually, we still use the clip that's placed by the radiologist after the biopsy. But then after that, the traditional way is the radiologist on the day of surgery would actually put a very soft wire in for us and either spear the tumor or go under the tumor. But the wire is very long. There are little segments of it, but it's sometimes hard to, when you're actually operating on the patient, actually know exactly where the center of the cancer is. So the radiologist now put this seed in, which can actually be put in place. It doesn't move, and it can be placed right on top of the tumor or underneath the tumor, so it can really centralize where we're excising.
And this pin tool you're using, this oversized pencil, it helps guide you down there better than like an X-ray would?
It does, actually. So X-rays are really two-dimensional, so we have two views. But when you're in there, the breast is three-dimensional. So we can use this probe, this radioactive counter at all times when we're excising the seed and the tumor.
Let me ask you this. Are you able to use, because we've talked to some of the other surgeons and other disciplines about robotic surgery, is this something that's in the offing for you folks, being able to make a minimal incision and do the minimal amount of damage to do great good?
I would love to do that.
Okay.
There are some interesting advancements in mastectomy techniques using endoscopy, where you use longer cameras. You do it through the armpit and an incision just below the breast. It's quite amazing. Most of the surgeons that do it are in Japan. But it makes sense. Faster recovery, better cosmetic result.
Armpit? I was surprised at that one. But yeah. Well, I notice you have Kimberly here as well.
Yes. So,
do you grow the seeds? Is that your job?
Well, she actually, yeah.
She's a seed farmer, yeah.
And she sort of planted the seed.
There you
Thank
go.
you to Kimberly for doing all the hard work to actually get the radioactive seeds so that we could use them for a diagnostic purpose as opposed to a therapeutic purpose.
Yeah, and Dr. Michael Stewart.
Oh,
is
you're
a
gonna get right.
radiologist. There we go. Dr. Michael Stewart is a radiologist that went for training and learned how to do the technique, and he's our what we call an authorized user on our nuclear regulatory license. So he spearheaded that piece of it, and I did the paperwork. But
Okay.
he's the one that did the work.
So when you say you use it for diagnostics, what are the uses for it? I guess basically. So far we've been just chatting about using it to help you find a cancer after you've already known it's there.
Yes. So most of the time, radioactive seeds are used in treatment of cancer. So they'll put the seeds in, like, say, for example, prostate cancer. They'll put multiple seeds into the prostate to treat and radiate the prostate for the prostate cancer. But this doesn't really treat the breast cancer. We're really using it more for diagnostic purposes and really to identify, exactly where the tumor is. So we can do a more precision, use more precision in excising the tumor.
Well, we're up against our first break. If you have a question or comment, give us a call, 721-1290. We have headphones for our guests, so give them headphone hair, but that's the hazard we face. Anyway, Elizabeth Sue and Kimberly Ryan O'Hara, both joining us here in studio from Community Medical Center. Health Talk will continue in just a moment. Okay, we're back on Health Talk. 721-1290 is the number. John King over there, Dr. Elizabeth Sue, and you are a surgeon, and you work with breast cancer patients, I'm assuming, every day. Is that right?
Yes.
All right. So I wanted to ask you both, let's go back into time, as the old song used to say, and look back maybe 20, 25 years ago, when someone would say, I'm sorry, Mrs. Smith, you have, we detected breast cancer, that all these horrible things come to mind about, removal and terrible, long surgeries and reconstructions and that sort of thing. How far have you come from then to now with the kind of targeted surgery you're talking about today?
Well, I think that back, probably in the 1980s, 90s, and early 2000s, it was all about being really aggressive with surgery. And now even some tumors are actually better treated if you do a lumpectomy and just remove the tumor with a good margin and then radiate the breast, and there's actually a benefit to that. We do less, it's probably more minimalist if you, and less invasive now with lumpectomy, and we're doing selective lymph node sampling. There have been a lot of studies to suggest more lymph nodes, and sampling more lymph nodes doesn't make any difference in the long term as to treatment. We're trying to answer, is there a need for additional treatment as far as broadening that radiation to the axilla or to the armpit. But trying to get that information doesn't require full lymph node dissection. And taking out a lot of lymph nodes can lead to chronic arm swelling. So you can cure someone of cancer, but then they end up with this problematic large arm,
Well, some secondary problems with that, right?
Yes,
Yeah.
yes, absolutely.
The last time you were on, you were mentioning like working towards this radioactive seed technique that now is a thing here in Missoula. And aside from armpit lumpectomy, what do you see in the future?
Well, I think that breast cancer surgery and treatments come a long way. I think that we do a lot less surgery. It'll be interesting to see, in the next 10 to 15 years if surgeons are even required to do any breast surgery, actually. We are learning a lot about genomic profiling of the actual tumors that each person has so that we can use that information and advise certain treatments that are very effective.
Like What? That's not surgery. So
That's not surgery.
eat more carrots.
Yeah.
What?
Well, a lot of most of the genomic profiling tells us a lot about the behavior potential of the cancer and the growth and the unpredictability. And so chemotherapy does play a role. However, some of the chemotherapy is less harsh than the traditional. And so it's a lot of what we call targeted therapy to particular bad genes in your cancer cell that can affect how rapidly they divide or how aggressive they can become.
So is it possible, as you look into your crystal ball into the future, is it possible for medical technology to actually genetically deal with that cancer cell and eliminate it from the healthy tissue without having to do all that surgery?
Well, it would be interesting. I think that going to some of the national conferences, there's a big push on certain types of even vaccines there have been studying about for breast cancer, and none of it has really been put into a major clinical trial. But it's interesting that there's a lot more medical advancements that are happening as opposed to surgery. We're doing a lot less than the medical therapies and so forth are very effective.
Sure.
So one of the things I was curious about, you were talking about using these seeds, these radioactive seeds for treatment. So I assume that works kind of like radioactive therapy, to kill the cells, the area around where the seed is. But you're also using the seeds as just diagnostics in a time where you might not want to kill everything around the seed, right?
Well, so when we use the radioactive seeds, it's really not for any therapeutics. There's no benefit to treating the cancer with the seed. It's really more of a technical marker that is much easier to localize than a wire tip. The wire is as long as a pencil, and we have to find about an inch or less at the tip within this non-transparent mound of tissue.
Right, it's mostly just like a hunt and find sort of situation.
Correct,
right?
yeah.
But when you're doing that, I mean, is there a risk of the seed causing problems? I mean, because it is giving off radiation, right?
It's such a small amount of radiation. It's not really a therapeutic amount as they would use in seeds for prostate cancer and so forth. So it really, and it's in for such a short period of time that it's very safe. We probably wouldn't have gotten the approval from the NRC to actually use it if it wasn't. But
it's kind of like similar to the cell phone. I mean, we carry these around our back pockets all day long. They've got we're bathing in emanations
Right.
nowadays, right? Yeah. So
interesting comment. Yeah, it'd be interesting to see which one gives more radiation. So
So you don't need to wear like a lead blanket for the time you're wearing the.
No, I have. When we put the seeds in, if we put them in 5-7 days prior, some of the patients, especially, you have older patients that have grandchildren. They ask you, "Oh, is it okay if I hold my grandson Johnny on my lap?" And you say, "Absolutely. It's a very low dose. It's safe. It's not that you're going to transmit radiation to other people."
it's all diagnostic, basically, right?
Yes.
Yeah. Okay. So it's not a high enough dose that it would be what you would call treatment. Where is that level? Where does that change from being just diagnostic to treating? So what do you think, Kimberly?
The the gamma energy from this I-125 is 40 keV. It's very, very low as compared to some of our other diagnostic radioisotopes that we use have like 140 keV. Some of our therapeutic isotopes that we use, in my world, I'm a nuclear medicine tech, can be up to like 360 keV. So you can see the big difference there. And then, of course, in radiation therapy, external beam would be much higher as well.
Okay. Strap on those headphones. We have a caller. Bob, you are on with our guest, Dr. Elizabeth Sue and Kimberly Ryan O'Hara. Good morning. How are you?
Well, thank you, Dr. Sue. My dad had radioactive seeds implanted in 1982 for prostate cancer, and I'd like to report that it has been a successful treatment of prostate cancer, arrested the prostate cancer, and he has not had any remission or any flare-up. He's had to have checkups every 6 months for the past 35 years, but it works.
Wow, and that was back in 1982.
Wow, how about that?
So how long have you guys been sitting on these seeds before you got around to
Right. Well, I think, and I'm not a urologist.
By the way, that's my entire lifespan.
I'm not a urologist, but I'm married to one, but I don't get any of that knowledge from osmosis. But I do know that radioactive seeds are very good treatment for certain patients with prostate cancer. we've tried different types of brachytherapy, and there have been studies looking at using something similar to seed, a little bit more radiation into the breast years ago, but just wasn't quite as effective. But using it now in a smaller dose for accuracy of locating these tumors has just been very helpful.
We're up against another break. When we come back, I want to talk about mammograms because from year to year, it seems like we have a new one. What are we doing? So all that, we're going to get directly from the source right here, ladies and gentlemen, and we'll be right back. By the way, we have all 4 lines open. If you still have a question for Dr. Sue or Kimberly Ryan O'Hara, we'll be right back. Hey, we're back on Health Talk. 721-1290 is the number. John King. I'm Peter Christian, Dr. Elizabeth Sue, Kimberly Ryan O'Hara, nuclear medicine specialist right over there. So anyway, I'm waiting for the submarine. All right, now let's talk about prevention. Let's talk about mammograms because from year to year, it seems we have different, one group says we should have them every year. Some say only after 40. So what does Dr. Sue say?
Well, we still, and speaking really on behalf of like the American College of Surgeons and the Breast Surgeons Society, is we recommend annual mammograms after age 40 with a good clinical breast exam. And then prior to 40, if you have a significant family history. There are actually 2 peak incidences of breast cancer that are totally sporadic, meaning no family history, totally healthy individuals, and that's in around age 50 and around age 70. So it's really important to continue with annual mammograms. And now, as people live longer, they're healthier. We're continuing a lot of these annual mammograms well into even 80, just because of their life expectancy.
Are mammograms covered under most insurance plans?
Yes, they are. And there are certain aspects of a mammogram that may not be covered by certain insurance plans, and it has to do with a particular tool that the radiologists use to assist with detection of different changes on the mammogram, and also the 3D the modality of 3 dimensions. But we have funding through the Community Cancer Prevention Center to also help with that if anybody has any trouble. So we hope that won't discourage people from getting an annual mammogram.
So when you go in for your mammogram, do you get notified up ahead? Hey, this might not be covered by your insurance, that sort of thing?
Yes, I think they're told that, especially for the 3D upgrade. But sometimes the what we call CAD, computer-assisted detection program, they don't always know that with the insurance plan. But again, we have patients that call us afterwards, referred by advanced imaging, and we try to help with that payment difference. So.
And one of the things I know that having wonderful females in my family, their doctors have encouraged them to self-exam. How often are you supposed to do that?
We not a lot of people like to self-exam, and I tell people, don't be too concerned about knowing exactly what you're feeling. I usually recommend, if you're comfortable with it, just getting to learn the texture and the contours of your breast once a month, and usually right after your period when the hormones are low. But I also have patients that are very lumpy and don't feel comfortable with that I don't put as much weight on self-exam as they used to.
Okay. All right. So now we have less than a minute left in the show. You guys have done great. We need some contact information for your office, and what do we do?
So if there's any questions, especially with when you should start your annual mammograms, or if you have a question about genetics in your family and how that might play a role, just call us at Community Cancer Care and Prevention on the Community Medical Center campus. And the Montana Breast Health number is 327-3943.
Great. It's a pleasure having you ladies with us. Thank
you.
You. Always great information. We appreciate it. All right, and that's going to do it for Health Talk for today. We'll have open phones on Talkback coming up here in just a moment. Rob Nadelson, under the weather, couldn't be with us today. We'll be back.